I decided to go into ophthalmology because I was working at my dad's eyeglass store. I sort of grew up in the eyeglass business. I made my first pair of glasses when I was 6 during the summer break. You know, when I decided what to do with my life, I said, well, you know, maybe I'll be an optometrist. My father's partner's son was in optometry school, and I actually went and visited an optometry school in the New York area where I'm from. I went there, looked, and I said, you know, I don't know, maybe I'll be an ophthalmologist. If I'm going to be an optometrist, you know, why not an ophthalmologist? Little did I know how much longer it would take, and it didn't really, it wasn't that important to me, the length of time. When we went to do our internship, you do before your residency for ophthalmology, you do a year of internship in really whatever you want, an unrelated field. So I did straight internal medicine, and I really loved internal medicine, and I almost decided to not take my ophthalmology residency, which was difficult to get into. It was a really coveted position, and stay to do internal medicine. But you know, I thought about it, spoke with people, and I stayed on course, and I never regretted a day since. When I went back to undergrad to do pre-med and was applying to medical school, I was already married. We've said, you know, we've lived in the New York area all our lives, so maybe we should venture out, but we had no money, and so we couldn't afford to apply on the West Coast or further. We applied not too far away, and we said, let's go to South. Maybe we shouldn't go too far south, you know, we're New Yorkers. Virginia doesn't sound too bad, so I got an early acceptance to MCV, and went to MCV. We liked Richmond, although we had plans to move back to New York, and you know, one thing led to another. I was looking around when I finished my residency, and there was a doctor retiring in town and wanted me to take over his practice, then I still, you know, I started seeing his patients, and another doctor said, you know, he started having me do surgery for him, and one thing led to another. I'm building this big practice, and so it's now about 25 years later, and we're happy we stayed. I think there's like really huge differences between where you go for your eye care. First of all, you can go to a local optometrist for routine care, contact lenses, and you can go to an ophthalmologist as well for routine care and comprehensive care. We do routine exams, but most of the patients have some form of pathology, if it's what we call in our general ophthalmology part of the practice, with glaucoma and cataracts and retinal problems like macular degeneration and red eyes and that kind of thing. It's a solo practice. I'm the physician here, and we have the best ophthalmic technicians. So in the eye care world, and especially with ophthalmologists, we don't use nurses. We use ophthalmic technicians. We look at the front desk people as equally important. It's such an important part of the practice. It really, you know, if they're friendly with the patients and attentive to every one of their needs. It's so important from looking at it from a medical standpoint, because you don't want things to ever fall through the cracks, and they don't let that happen. Then you have the whole field in ophthalmology, let's say with laser vision correction, LASIK, where you have corporate centers that have to answer to the stockholders, and they have a physician that doesn't live in the area. They either fly around or drive around from state to state. It's just amazing to me that that actually occurs. I mean, it's more, for a surgeon, it's more than just doing the operation. It's the surgeon's skill that's so important in evaluating the patient preoperatively. You can't really delegate that to someone else. I mean, how could you? The surgeon has to be involved in your case before he operates. He needs to certainly be there during the day of surgery, but and most important, he has to be there afterwards. I'm a solo practitioner with great staff, and I'm here all the time. Matter of fact, when I started doing LASIK well, about 15 years ago, when I was one of the only people in the United States doing it, I dropped out of a call group that I was in when you're on call because I didn't feel it was fair for the patients, because the other doctors really didn't know how to take care of LASIK. And so for years, I'm on call all the time. Again, you know, when I compared solo practice with corporate entities, we're also not a local big clinic where there's 30 different ophthalmologists. I mean, you'll see me from beginning to end, and I'm here. I'm not going anywhere. You know, if you're coming for me for the things that I do, I'm here before, during, and after, and that should. I just think that's the finest kind of eye care for what I do, and I wouldn't compromise that. You know, if somebody is concerned with just the idea of somebody, you know, doing surgery on their eyes. I mean, LASIK is surgery. I can understand that. I mean, I can relate to that. And some people are going to be more afraid than others, and it's a real fear. And I would really question it if you didn't have some fears. I'm so paranoid myself. I mean, in terms of protecting my patients, I mean, I don't want to do anything that's going to hurt anybody. And that's why I flew to the ends of the earth and did all I did, all the somersaults and hard work and all this, just so I could make sure that I didn't hurt anybody. So I trained with the person who invented it, and made sure that first the procedure was good and that I did it correctly. Research, you know, how safe and effective it is. So you want to, number one, learn about the procedure and learn about your surgeon and the facility that you're going to. What happens with contacts? You know, patients just put a piece of plastic in their eye and think, oh, that's nothing, and they don't even think about it, but they worry about LASIK. So I'm not saying don't worry about LASIK, but I'm saying you should be worrying about contacts, and that contacts cause infections, sometimes horrible, nightmarish infections, and not as rare as you may think it is. My wife, who I met at my dad's eyeglass store, who was wearing contacts for years, I don't know, some reason she had trouble you know, putting the contacts in and out, you know, but she would do it, but she would just sleep in them. And it used to drive me nuts. I mean, I knew she was a ticking time bomb. And so as soon as I could get my hands on her to do LASIK, because I knew how safe and effective it was, I did my wife in the 90s. And so she doesn't wear glasses anymore. She used to wear thick glasses. I think it's fair to question it, to be afraid, to have a caution, proceed with caution. But I can tell you that LASIK is an extremely safe procedure. You know, I do cataracts, a lot of cataract surgery, and that's one of the safest procedures. It's, let's say, 98% safe, which is very safe. LASIK isn't 99% safe. It's safer than, in the right surgeon's hands with the right technology, safer than 99.9% safe, and that's what you'd want it to be. One of the major things for safety is screening out those who aren't candidates, and that's one thing that we do really carefully. And that's where you can't take shortcuts. And you really need to have the surgeon involved in the preoperative evaluation to make it as safe as possible. To plan the technique based on the patient's anatomy and all that kind of thing, and have all the latest technology like wavefront and blade-free intralaser technology available. LASIK was very safe when I learned it in the 90s. Now, it's with all the safety fences built around it, it really is something I feel comfortable doing, and I would prefer patients from your eye care provider to have, from looking out for your safety, to have, if you're a candidate, to have laser vision correction than to wear contacts. If somebody asked me, why, should I proceed? I'm nervous, and I would tell them these things and tell them that, me, Nervous Nelly, feels comfortable providing this for you. If someone was told that they're not a candidate because they're over age 40, I mean, that would really get under my skin. Unfortunately, there's lack of education and knowledge of surgeons doing LASIK about what I call blended vision. For years, the optometrists used what we call monovision, which is really not an accurate term and a misleading term. but setting one eye for far and one eye for near with contact lenses. I provide something like that for all of my LASIK patients. Again, I call it blended vision. There's an art to it. You need to set the dominant eye. First, you have to determine which is the dominant eye. That eye, for some reason, I don't know why, but the brain prefers that eye seeing better for distance. And the non-dominant eye, you set with a little nearsightedness that helps it see up close. But both eyes are seeing far, and both eyes are seeing up close, but one is seeing better for far, and one's seeing better for near, and the brain puts the two together as long as there's not too much of a difference between the two eyes. So you end up having your cake and eating it too. You're seeing far and you're seeing near, but it's only 1 out of 100 that just can't tolerate any difference between the two eyes. They'll go, oh, well, look out there, it's blurry, but if I close that eye, it's clear. Then you know, okay, that 1 out of 100. But 99 out of 100 just love it. The 1 out of 100, you just bring them back and set the other eye for distance, and then they're happy. They don't mind wearing their reading glasses. They're thrilled. And for some reason, the older you are, the more the brain can tolerate the difference between the two eyes. So I know from experience, you know, at what age you're at, about how much I can give you. So if you're in your 20s and 30s, I don't give you any. You don't need it, and you're not going to tolerate it. But when you hit at the age where you need it, it's nice that the brain has allowed you to just put the two images together, and they're just up and running from day one. I do that on all of my patients, 40 years or older. And so if you're thinking about having LASIK and you're in that age category, recognize I can get you to have your cake and eat it too. What do I do outside ophthalmology? That's a good question, because so much of my life is tied up with ophthalmology. Ophthalmology is not just my work, but it's my hobby. It's hard to turn it off. The first thing with ophthalmology is that I feel I have a big responsibility. So, you know, I have to stay focused, you know, all the time. As I had said, you know, I'm on call all the time. It's not enough just to know what you know now, but you have to constantly be learning new things. And I'm also involved in pushing the bar forward with my own research, which is very time-consuming. But on the other hand, I have so many other things that I could be doing, but I've chosen to spend the vast majority of my time taking care of my patients and making it as good as possible for them. My wife has created so much. While I've been so busy in ophthalmology, she's created another half of my life, and I have to owe her so much credit for that. Raising our 3 boys. I grew up very athletic. I played high school baseball and played every sport. I guess that rubbed off on my kids. I have 2 kids that one's in veterinarian school and one's in Hollywood doing computer animation, but both are tennis pros. And my middle son lives with us, and he's has Asperger's syndrome, high functioning, moderately high functioning autism, and we're very involved in the autistic community in Richmond, especially my wife, who runs a theater group for what they call the Dreamers, for autistic young adults and others with learning disabilities. So we're very involved, and for years with raising our kids, and they're never so old that we don't worry about them. One is now taking up rock climbing. That scares the heck out of me. The other one's in Indonesia on an island doing research with the shrimp farmers. And so we do some farming in our backyard. We have what you call an edible garden. So most of the plants that we have are edible, whether it's vegetables or berries or fruit or herbs. If we had to depend on our harvest, we'd be really skinny. But it's a lot of fun, and we work hard, and so I just do what she tells me to do. We do our fair share of traveling, especially now in the research I'm doing. I've been traveling around a lot recently. This year I was presenting things with, my wife came along. We were in Paris and Chicago and San Diego recently. And so very busy life that we've created for ourselves here in Richmond. If I had more time, I guess I'd be involved more with music. And I have a son who's a drummer, and I'm always whistling tunes and coming up with tunes. And I have them in a tape recorder I store constantly, but I never have time to really write the music or you get it down in any formal format. But I save them on tape. Someday you'll hear a tune by me in your hometown. I chose the technology that we have for specific reasons. The whole concept was invented by Steve Trokel, an ophthalmologist, PhD, laser expert at Columbia University in New York. And once he had that up and running, it became a company called Vuzix. And he brought on board early on in their research one of the top optical engineers, provide all the optical knowledge that they needed to take this laser that was etching computer chips and turning it into something that could change very elegantly the shape of the cornea to solve things like nearsightedness, farsightedness, and astigmatism. And Dr. Mullenweg, you couldn't find anybody better in the world to do that. And they were the first ones to do this. The best thing was that they maintained a very high level commitment of R&D to keep advancing it all the time, to making it better and better. And so Vuzix was the gold standard. And so I chose Vuzix early on and stayed with them. They have the wavefront technology, which gives a very fine corneal curvature to correct every little imperfection or idiosyncrasy of your individual corneal shape. Everybody's corneal shape is different than everybody else's, just like your fingerprint. And wavefront technology enabled us to custom do your treatment because it could not only read your fingerprint of your eye, but it could actually change it. I used to pride myself in my skill before we had trackers to center that laser ablation right on the center of the pupil, and some patients move their eyes more than others. And I was really good. I really did pride myself that we had very centered treatments and great results. But I cannot compete with the high-tech trackers that they have today. This tracker will follow every little movement that you make, and if you move your eye off to too far an extent and the laser's then treating at such an angle that it will decrease the effectiveness of it, the laser knows to shut off. Then they top themselves again with iris registration, where they're going to take a picture of your iris, the colored part of your eye, and that, everybody's iris is unique. And then when you lay under the laser, it takes another picture and it goes and just matches the two, so the laser will rotate to the position that your eye was when you were seated. And at the same time, it's finding the center of your pupil and locking on with that tracker that I talked about. So it's aligned, it's centered, and it gives you a perfect result. The intralaser laser was something that came along later. That was technology that is in the field of what we call ultra-high speed, because what this does is it, underneath the surface of the cornea, no blade, it just lays down a layer of hundreds of thousands of tiny microscopic bubbles that in one sheet at a very specific depth, whatever you set it for, and those bubbles will expand and separate out the layer of where they are in the cornea. And if for some reason, like with the microkeratome, if something was to go not the way you want, well, with the microkeratome and a blade, something's already happened. But with the intralaser laser, in those rare cases where something happens, if you just don't do anything, you don't try to lift the flap, the bubbles just dissipate and go away, and it's as if we did nothing. It's miraculous. So it has this incredible level of safety. It's just, the bar was raised way high. But any surgeon who knew enough about what was going on would love to have that laser, but couldn't afford it. I didn't care. It was for safety, so I was getting one, and we got it. I waited for it to come through a few generations. They were still working out some bugs, and then it had gone right to where I wanted it, and it never disappointed me. It filled the bill. It gave me everything that I wanted. So it made that very rare, less than 1 out of 1,000 complication that you could see with the microkeratome to really where you want something like this. Less than 1 out of, I don't know what the number is because it's so rare, I've never seen it. So, but it's really added safety. It's another bell and whistle and fence of safety that we've brought around this procedure. If someone was to have another excimer laser, you know, from another surgeon, I'm not going to argue that hard, even though I would argue that the Vizix is better. But I would argue very strongly about having blade-free LASIK. I mean, if you want a safe procedure, you can have it with the microkeratome. But if you want to have the safest procedure, why risk anything? Have the intralase procedure. Nothing's risk-free, but this has really raised the bar very high.